This is the beginning of a series of tutorials on obstetrics, and specifically for medical students going through their OBG rotation. And today I'll give an overview about obstetrics and also talk about pre-pregnancy counseling and antenatal care. So basically, obstetrics is the study that centers around pregnancy. And to start with, ideally in modern day medicine, everybody should have some form of counseling before pregnancy. And the aim of pre-pregnancy counseling is to identify any problems while trying to conceive, so such as in the case of infertility. And you would also like to optimize the woman's condition to get pregnant. So things like folate, vitamin, vaccinations, and if the women have some kind of medical conditions, you would like to optimize control so that it doesn't impact or produce an adverse outcome to your pregnancy. And if the woman's had a pregnancy before, you would like to have an idea about how that pregnancy has gone, so that you have an idea about what is to expect, because the past will predict your future, basically. Once the woman gets pregnant, there will be antenatal care for everybody. And the goal of antenatal care is basically to screen for the common complications that might make the pregnancy dangerous for the mother and also the baby. So common ones on the mother's side, you're looking at preeclampsia and also gestational diabetes. And for the baby, you're looking at any congenital anomalies, congenital infections, and also growth restrictions. Once the pregnancy occurs, there's not much you can do in terms of treatment. So the important decision might be how you want the pregnancy to end. So basically, if there is a congenital anomaly as a result of a chromosomal disorder or congenital infection, then you know that the baby might die in the mother's uterus. Or if the baby survives this pregnancy, he or she will have some severe issues. And that may not be something that the family is expecting or is able to cope with. So that is a chance for you to bring up the topic of termination. And if the pregnancy is to continue, the important question might be when and how you would deliver. And to answer that, you have to evaluate the benefit and risk of staying in versus getting out. So basically, to stay in the presence of a pregnancy complication such as preeclampsia, there is increased risk for the mother and also the fetus. So the mother might be endangered by the complications, such as in the case of preeclampsia, it might progress to eclampsia, and the mother may be actively fitting. And for the baby, you're looking at, of course, fetal death in utero. And the risk to get out, the pregnancy complication will resolve. But the baby is less developed, and thus there will be an increase in perinatal mortality and morbidity. And the critical time for that is 37 weeks. So any baby born after the 37 weeks is considered term, and any baby born before 37 is considered preterm. And there is a dramatic increase in terms of perinatal mortality and morbidity if you were to be born preterm. So the exact timing of delivery will depend on two things. Number one, the severity of your complication, and number two, whether your control is good enough. So with good control, you can have the baby born at 37 weeks or even 38 weeks. So a term baby. But if you have bad control, or if you are having severe complications, that risk might be even more than the risk of increased perinatal mortality or morbidity with a preterm birth. So you will deliver the baby before 37 weeks in this case. And in extreme conditions, there might be immediate danger to the mother or the baby. And in this case, you have to just get the baby out immediately. And whether or not the baby will survive is a question for later. And as the pregnancy approaches its end, you would like to consider how you would like the delivery to happen. So basically 2 choices. You either have a vaginal birth or a elective cesarean section. So if you're looking at a vaginal birth, you are thinking about whether you want the labor to occur spontaneously or do you want induction of labor. So the good thing about induction of labor is that you can have it happen in the time that you want it to happen. And for vaginal birth, there is risk for vaginal birth itself, so it puts stress on the baby, and that can cause fetal distress. And of course, labor may fail to progress. There may be shoulder dystocia, so the baby might have difficulty getting out. And in that case, you might have to assist the delivery with a instrumental delivery, so such as using a vacuum or a forceps. And if you still can't get the baby out, you need an emergency cesarean. So for elective cesarean, you are basically first thing first, it's better than an emergency cesarean in terms of complications such as infection and bleeding. So if you're gonna have a Caesar, it's better to have an elective rather than emergency. And if you elect and cesarean section basically is more suitable for increased for baby that have increased risk. So for example, if the babies have growth restriction, so they have less reserve to cope with the pressure they will be put under for a vaginal birth, you might consider a elective cesarean. And also, in the case of gestational diabetes, the baby might eventually become quite big. So that's what we consider to be macrosomic. And with a big baby and a small birth canal, you are expecting things like failure to progress and shoulder dystocia. So that might also be a reason for a elective cesarean in the first place. And after delivery, there might be some issues such as postpartum hemorrhage and lactational issues, and we will talk about all of them in detail later. So today, the first thing to talk about is pre-pregnancy counseling. And the purpose of pre-pregnancy counseling is basically, as I said, to optimize the condition of the woman to get pregnant. And this will involve also some general advice and information giving, and gain some knowledge about what's going to happen in the future. And the history taking will be slightly different compared to a let's say a emergency department presentation. And I'll also talk about how you would take a gynecological and an obstetric history and why they're important. So first thing is to gain some knowledge about the woman's demographics. Age is very important because, of course, with increasing age, you are looking at decreased fertility and increased risk for complications such as miscarriage, preeclampsia, etc., etc. Marital status, contact address, they are basic stuff, and religion is something that you would like to know as well, because, for example, a Muslim woman would not like to have a male obstetrician or a male medical student to observe. So let's start with gynecological history. So the first thing for a gynecological history will be a menstrual history. A menstrual history is important because a woman's period is indicative of the consistency of ovulation. And of course, to get pregnant, you need the woman needs to ovulate in the first place. And if you have irregular periods or very long cycles, it increases your difficulty of getting pregnant. And it might also point to a treatable condition that might prevent pregnancy from occurring, so such as PCOS, for example. So details about the menstrual history. So basically, you would like to know about their last normal period, and also about previous periods. So menarche is when is the age when the woman starts to have their periods. And also you would like to know about cycle length. So how long is a cycle? Is it long, irregular? Any issues such as heavy bleeding or heavy pain? Sexual history is also very important. So number one question to ask is duration. So how long have you been trying to get pregnant, if you have been trying at all? Because if you've been trying for 1 year and without success, it is considered infertility. And that is without any risk factors in the first place. And frequency is very important as well, because increased frequency of sexual intercourse increases your chance of getting pregnant. And there might be some issues that prevents the couple from having sex more frequently, such as, for example, the woman might experience pain. The man might have something like erectile dysfunction. There may be some social issues, such as geographical separation. So, for example, the woman might be working here in Melbourne, Victoria, and her husband may have to fly all over the place. And if they don't have enough time together, they don't have enough sex. Means of contraception is also very important because, for example, if you're using oral contraceptive pills, the dating methods might be a bit tricky. And also, if you are using an implant, it might delay your return of fertility. The rest of the gynecological history is basically to know about any previous STDs, any known gynecological conditions, and of course pap smear results. Then we move on to obstetric history. So if this is the first time the woman is considering a pregnancy, this is not relevant as part of pre-pregnancy counseling. But if the woman has had pregnancies before, there are two important things you ask first. So number one is gravidity, number two is parity. Gravidity basically means the number of pregnancies that the woman has had previously. And parity means the number of pregnancies that's being carried beyond 20 weeks. So the questions you might ask will be, number one, for gravidity, how many pregnancies have you had? And for parity, how many children do you have? And if there's more G's than P's, then you know something's gone wrong in between. So for each pregnancy, you would like to know what's been happening from start to finish. So number one, whether it is a single or multiple pregnancy. Throughout the pregnancies, were there any complications such as preeclampsia, gestational diabetes, growth restrictions, infection anomaly, etc., etc.? How their controls were, and in terms of delivery, when did it happen? Was it preterm or was it term? So how many weeks did it happen? And were there any difficulties during labor, so such as pain and progress? Were there any need for instrumental delivery? Was the birth vaginal or cesarean section? And importantly, if the baby was delivered via a Caesar, you need to specify the reason. Because cesarean sections might be an emergency cesarean section, because of fetal distress or failure to progress, or it might be a elective cesarean section, such as intrauterine growth restriction. And for each loss, you want to know also about what happened. Was it ectopic? Was it miscarriage? Or was it aborted? And then the past medical history. Past medical history, the important thing is basically to see if there's any medical condition in the first place, if there's any medical condition that might impact on your pregnancy that's otherwise avoidable with good control, and also if there's any strong contraindications to pregnancy. So screening questions might be, do you have hypertension, diabetes, other things like thyroid disease, hepatitis, and there's a few strong contraindications to pregnancy as well. So number one is renal failure, severe renal failure. Number two is pulmonary hypertension, so such as if the woman's had recurrent pulmonary embolisms or a mitral stenosis. And the third important one is type 1 diabetes with complications, so such as retinopathy or nephropathy. And in this case, if the woman, it's best to avoid pregnancy at all. If the woman wants to get pregnant, she may consider adoption or surrogate. Then surgical history, of course, and importantly, vaccinations. Vaccinations against the torch organisms, and we'll talk about that in a bit more detail. And then medications and allergies. So standard questions, basically. For family history, you're looking at any chromosomal or genetic disorders that goes in the family. Social history, standard questions, smoking, drug, alcohol. Occupations. These are pretty standard. What's different will be, you would like to know in this case how much support the woman has at home. So number one will be home arrangements, so who are you living with, and financial status is important. And importantly, you have to screen everyone for domestic violence. So that might be a simple question, such as, is everything all right at home? Because domestic violence is not as recognized as it can be, which is important. So the investigations that might occur during pre-pregnancy counseling may be rubella and varicella zoster immunity status, because if the woman was to be infected during their pregnancy with these two viruses, it can cause pretty bad complications for the baby. So other investigations will depend on the medical conditions of the woman. So for example, thyroid disease, you need to check their thyroid function. You need to optimize their control before they get pregnant. Diabetes, you might have to look at renal functions, ophthalmology, and you can consider a pap smear if it's not up to date. Then you would like to ideally optimize the management of the medical condition. So the principle will be to optimize control and to avoid teratogenic medications. So for example, in the case of epilepsy, you would like to avoid valproate, and if you are changing the medication drastically, you would like to observe the woman for about 6 months to see if they have good control or not. If the women have hypertension, one of the very common medications used for hypertension, ACE inhibitor, is a teratogenic medication. So you might want to change that to methyl-dopa or labetalol. For diabetes, you change their oral hypoglycemics to insulin, basal bolus regimen. Warfarin is teratogenic, So if the woman's on warfarin for some reason, you would like to change it to heparin. And cytotoxic medications such as methotrexate, you have to stop it. So some general advice before getting pregnant. The time of pregnancy, median duration is 4 months. So half of the population gets pregnant within 4 months. And sexual activity, you will at least need to have sex every second day towards ovulation, and ideally, of course, as much as possible. Infection control is very, very important because with immunization, you can avoid infection almost entirely. And these infections can cause a lot of problems with the baby. And for the behavior part, the most important thing will be good hand hygiene. And for TORCH organisms, so TORCH stands for T is toxoplasma, O is others, so such as parvovirus, R is rubella, C is CMV, and H is herpes. So these organisms can cause congenital infections and severe anomalies with the baby. So to avoid them, avoid kissing kids in the face, avoid contact with people with febrile illness, and in the case of toxoplasma, cat litter is also best avoided. Another thing to be concerned about is listeria. So listeria can cause meningitis in babies. So to avoid them, it's best to avoid eating undercooked poultry or seafood. In terms of lifestyle, smoking, alcohol, drugs, avoid them. Smoking is known to increase risk of miscarriage and pregnancy complications, such as preeclampsia. So avoid that. Drugs, you should avoid them anyway. In terms of alcohol, moderate drinking is not proven to have any ramifications for the pregnancy, but it's best to avoid it at all. It's best to avoid it anyways. Sex is not harmful throughout pregnancy. Exercise, moderate exercise is encouraged. Strenuous exercise is actually considered to cause small babies. So an example of moderate exercise may be brisk walks instead of running or any contact exercise. Swimming is a good one as well. So in terms of walk, most women stop at 34 weeks, but in the case of any complications such as preeclampsia, you might consider stop walking a bit earlier. In terms of diet, it's important to ensure a balanced nutrition, and there's a few supplements you need to take. So folate is very important because folate prevents neural tube defects. And you need to start taking folate before getting pregnant. So 3 months before pregnancy and carry on throughout the first trimester. Multivitamin is, I think, recommended for everyone. And depending on the woman's deficiency, you might consider vitamin D or a iron supplement. The woman might be concerned about safety of medications, and it's a chance for you to give some information about what medication is safe for symptom control throughout pregnancy. So for pain, you can use simple analgesia such as paracetamol. And for nausea, morning sickness, Maxilon is very safe. And UTIs, you can just use penicillin. So once the woman is pregnant, then we move on to antenatal care. So the first thing is to confirm pregnancy, so to know for sure that the pregnancy is there. There's a few indicators in terms of symptoms and exams. So symptoms of pregnancy are, of course, missing periods, morning sickness, breast tenderness, urinary urinary frequency, things like that. Examinations are not very good in terms of confirming pregnancy, but rather to follow up on how the pregnancy is progressing. So uterine enlargement is palpable abdominally at 12 weeks, and later on throughout pregnancy, at each visit, you would measure the fundal height to see whether the baby is growing as it should be. So ultimately, you will have to rely on biochemical confirmation. So serum beta HCG is 100% reliable, but urine HCG can have false positives and negatives. So you have to ask the woman how do they know they are pregnant, and ideally everybody gets a serum beta HCG anyway. So the next thing will be to determine the gestations. So now it comes to the importance of knowing the woman's last normal menstrual period, because the traditional dating method called the Nagel's rule. So Nagel's rule says expected date of delivery is 9 months plus 1 week after the last normal menstrual period. And in that case, the normal a cycle is considered to be 28 days. So if the cycle is longer or shorter than 28 days, you have to adjust upwards or downwards. And if the woman has just recently come off oral contraceptive pills, or has irregular period, this method is not going to be reliable. So I think ideally everybody gets a dating scan, which is very reliable. Depending on the gestational age, there's 2 different parameters you will look at to date the baby. So the important time in this case is 12 weeks. So before 12 weeks, you look at the crumb rump length, and after 12 weeks, you look at the biparietal diameter. So other routine tests upon the first visit. So blood type is important. So you would ideally want to know the rhesus type to identify any rhesus negative woman. And also look at any red blood cell antibodies such as Cal and Duffy. The importance of that is that it might cause, in particular for rhesus negative women, there might be a phenomenon called the isoimmunization. So that is the case where a rhesus negative mother has a rhesus positive baby based on a rhesus positive father. So in this case, the woman may be sensitized with the first baby, and with the second baby, it will cause the mother's immune system will recognize the rhesus positive antigens on the baby's red blood cells and start attacking them. So that would eventually cause fetal anemia and also high output cardiac failure, which in the case of the baby is called fetal hydrops, and that can be a bit dangerous. And that's treatable as well. You can give something called the anti-D to stop that isoimmunization from occurring. And FB for everybody. Serology for rubella and varicella zoster, because they can cause severe anomalies in the baby if a congenital infection is to occur. And also everybody gets STD screenings. So it includes 3 viruses and 3 bacteria. So virus is HIV, HBV, HCV. The 3 bacteria are chlamydia, gonorrhea, and syphilis. So common stuff. And also you would do a midstream urine to see if there's any asymptomatic bacteriuria. Then we move on to trisomy 21 screening. This is not done in the first visit, but a bit later on. In short, NIPT, so non-invasive prenatal testing, is the most accurate test. It's a bit expensive, but it's good. Otherwise, the mother can choose the combined first trimester testing, which is a combination of three parameters. So nuchal translucency on an ultrasound, the mother's serum beta HCG, and also something called PEPA. So in this case, the NIPT and also a combined first trimester test are both screening tests. So if the screening test yields a high risk, then the woman is referred for diagnostic testing, which is chorial venous sampling, and that has a slight risk of miscarriage, about 1%. So the frequency for future follow-ups, there's again two critical time to remember: 28 weeks and 36 weeks. So before 28 weeks, it's a visit every 4 weeks. Between 28 and 36 weeks, it's every 2 weeks. And after 36 weeks, the baby is towards term. So you would like to have weekly visits. And these are standard time frames for a nulliparous woman, so a woman who's not pregnant before. And for a multi, you might have less often visits. So at each visit, there's a few assessments you do. So in terms of history, there's two questions you ask always up front. Number one, are you well during this pregnancy? Number two, you confirm the fetal movement by asking, is the baby moving all right? These two are very good combinations, because the first one enables you to open up a discussion of potential complications or symptoms that you can offer advice or treatment for. And number two, fetal movement is basically to confirm that the baby is still alive. Examinations for the mom, you weigh the mom to ensure that the weight gain is adequate. And also importantly, to screen for preeclampsia, it's simple. You measure the blood pressure and you do a urine dipstick to see if there's any protein in the urine. And for the fetus, you would palpate the abdomen to check the fetal lie, station, and presentation. So the lie is basically whether the baby is straight down the birth canal or is at an angle. And the station is basically how much down the pelvis the baby is. And the presentation is basically what the baby presents to the birth canal. So it's at the vertex, which indicates the baby is presenting with the face. The breech presentation, the baby is coming out via its buttock, and footling presentation is basically the baby's foot is coming down the birth canal first. And you measure the fundal height to screen for intrauterine growth restrictions, and you do a fetal heart rate to basically confirm the baby is alive. Then there will be periodic assessments. So again, 28 weeks is very important, as you see there's quite a few tests being done. But before that, there's an 18-week anomaly scan, so to check for any congenital anomalies. And at 28 weeks, there's screening for gestational diabetes, which is in the form of a oral glucose tolerance test. There needs to be a low vaginal swab to check for the GBS status. So GBS stands for gram-positive. I actually forgot about what GBS stands for, but doesn't matter. GBS is a bacteria that is present in a lot of women, and with the presence of GBS, and it may cause infections or pneumonia, meningitis in the baby. So knowing that gives you a chance to administrate antibiotics to avoid that risk, basically. And FBE for everyone to check for anemia. And if the woman is rhesus negative, you would, at 28 weeks, give the woman anti-D and check for their red blood cell antibodies. And at 36 weeks, normally there shouldn't be any investigation needed. But if there's a rhesus negative woman, you would check again for red blood cell antibodies. And if the woman was anemic, you do a FBE again to see if the HB is up. That is it.